Thank you, Nigam. And such a great pleasure to be here this morning or whichever time zone you are. Quite an honor. And I do want to begin by saying I'm one of the beneficiaries of this incredible ecosystem here at Stanford where clinicians collaborate and really intellectually lead many of us here at computer science to do the AI healthcare and AI medicine research. And of course, Kurt, Matt, Nigam, you guys are the leading scholars and doctors, and it's quite an honor to be in this ecosystem. And today, I just want to spend some time and sharing with all of you the recent work I've been doing called Illuminating the Dark Space of Healthcare with Ambient Intelligence. When I say recent, it's still been 10 years. And I want to just, from the get-go, acknowledge the incredible partners that we've been having. I cannot possibly list them all, but the two people I want to highlight are Dr. Arnie Milstein, who is a professor of medicine at Stanford School of Medicine, who has been one of our country's leading thinkers in healthcare delivery. And he has really practically held my hand in the past 10 years, guiding me through this very new area of research. And the bulk of the talk is work done by Albert Haag, who has just finished his PhD at Stanford in my lab. And we've got a lot of clinicians, computer scientists, ethicists, law scholars, political scientists, and computer security experts to thank in this collaboration. Let me begin by saying that modern medicine, especially in the past 100 years, is breathtaking. The kind of technological improvements in modern medicine is just amazing, and we've seen that in all aspects of this. And I won't belabor all the things we should really thank and celebrate. But let's just look at a very sobering fact, is that despite all the modern technical advances, medical errors are still estimated to be the third leading cause of death in the American healthcare system. And in fact, it is estimated that more than 250,000 patients die every year due to medical error, according to a National Institute of Health report, as well as other studies. Some people put this number as high as 400,000. In comparison, car accidents or traffic accidents cost 37,000 lives. So this is a daunting number, and this number keeps me awake at night. Both as a researcher, but as well as someone who's been taking care of my aging parents and very sick aging parents for the past 3 decades. So what makes this number so high, and what makes healthcare so hard? Part of it is that it is a very complex space of care. In fact, spaces of care, whether you're looking at operating rooms, documentation, pharmacy, primary care, inpatient rooms, ambulatory care. We have a lot of human activities involved. There's a lot of process, protocols. And whenever there's human, we err. This is part of being human. And so there's no ill intention, yet we haven't achieved the results we want. This actually reminded me, when I got into this area of research, a similar space that has caught the attention of AI field and technology, possibly earlier than healthcare delivery, and that's the space of driving. It is also a very complex space of very complex human behaviors along with the environment, and the stakes are high. And if you are not sleeping for the past 10 years, you know that self-driving car has, that technology and that aspiration has taken over the world of transportation and mobility, and we're inching towards that dream, even though we haven't achieved it, through the integration of really exciting mapping, sensing, algorithm and system and hardware technologies. So this is what Arnie and I see with our students, is that we have a similar opportunity here to endow healthcare spaces with the similar kind of ambient intelligence, while smart sensors and machine learning and AI algorithms. And the goal here is to reduce medical error, to illuminate the dark spaces of healthcare, where understanding human behavior, patient, clinicians is so important. And in short, how does this happen? Well, first, we have to enable the physical spaces of healthcare with sensing ability. We want to shine the light figuratively. It doesn't have to be a light, but to be able to see information in the physical spaces of care, whether it's ICUs, operating rooms, inpatient rooms, primary care clinics, or aging homes. And then behind the scene, smart and sophisticated machine learning algorithm will start to interpret important human behaviors relevant to critical clinical outcome. And that would give us a new source of information that is hardly ever gleaned in today's healthcare practice. And of course, this is all to be integrated within the full clinical ecosystem. So that was the rough idea of what ambient intelligence in healthcare is. So for the rest of the talk, I will organize it according to a recent Nature paper that Arnie and I and Albert have published, kind of summarizing what we have done in the past 10 years, and also what other groups of researchers have done. Of course, due to time, I'm just going to highlight a couple of work. We organized our research, actually, as well as this paper in healthcare delivery by two major healthcare spaces. One is hospital inpatient space. The other one is daily living space, focusing on aging population. So let me just start with the hospital space. There are many uses and applications of ambient intelligence, whether it's ICU, operating room, and other spaces. The paper is much more comprehensive. I'll just highlight a couple of things in the ICUs. I'm talking to this audience, and I don't need to convince you how important ICU is, the expenses, the life and death battle of our patients. So it's a really important place to ensure patient safety and patient recovery. And one of the recent clinical studies have taught us that despite how sick the patients are in ICUs, their mobility and proper mobility is actually important for their recovery. But doctors have started to prescribing proper amount of mobility, whether it's moving in the bed or sitting up or even moving to a chair, depending on the patient's situation. But here's a question: how do you measure mobility? This is hard, right? It's not a vital. You cannot stick, a needle against some blood. So it requires direct observation. But whose direct observation? Our nurses are absolutely overworked, and we cannot count on the patient. So this is actually a problem. So we began to collaborate with Stanford Hospital and Intermountain Hospital. And the idea is to put sensors in the patient rooms and help doctors to observe the movements patients have made under guidance mostly. So every orange dot you see here on the floor map is a smart sensor. In this case, it's a depth sensor, and the arrows point to the range and direction the sensor sees the room. And we'll get into the privacy issue, but just you can see from this kind of video segments that we actually care a lot about privacy, and depth sensor is one step towards protecting privacy and not revealing identity. And so using machine learning algorithms, we can actually analyze the movements. We can categorize movements like getting out of bed, sitting in chair, getting back to the bed, and getting out of chair, and all this. And not only we can do that, we can do it in a continuous way, contactless and continuous way. And we have tested our algorithm against ground truth. The short answer is the machine learning algorithms are really, really robust in classifying different movements. Here we just tested 4, but we absolutely are interested in going much deeper into the more nuanced movements in clinical care, where it really matters to prevent pressure ulcer, oral infection, and other conditions. And in one thing that excites me in this clinical collaboration is that the use case pushes for the frontier of computer science. Within the field of computer vision, understanding fine-grained human activity is an unsolved problem. And now we can contextualize this into healthcare usage and make the work even more meaningful. So that's just one example. I'm gonna try to talk fast for the rest of the talk. A second example in the inpatient room is hand hygiene. And when we started hand hygiene with Lucile Packard Children's Hospital here at Stanford, it was kind of an arcane project, other than the appreciation of some of the doctors we collaborate with. I guess COVID have taught the public how important hand hygiene is. But I didn't know this. It's sad to know that hospital-acquired infection is one of the top killers of our patients, and it's extremely expensive and dangerous if patients are infected. The cause is not just malpractice of hand hygiene. There are other causes, but good hand hygiene practice by our clinicians is critical in the hospitals. But how does hospital measure good hand hygiene practice by our clinicians? It is hard. Most hospitals today still uses human monitors to audit these hand hygiene practice in a very sporadic way, and it's very subjective and time consuming. There has been technology attempts like RFID, but they're really, really coarse. It really measures proximity to gel dispensers or sink, not the actual performance or movement of hand hygiene practice. So we piloted a study with Lucile Packard Children's Hospital and Intermountain by putting sensors on top of dispensers and watching, again, this kind of videos, watching human movements before the clinicians go in and out of the room. And behind the scene are some deep learning algorithms analyzing nuanced human movements. And also there's some technical challenges to actually link tracks of one person from one camera to another camera. I'm not going to belabor this point, but here's an example where the green box indicates that the person has performed the hand hygiene act before entering the room, and the red box shows that this person has not performed the proper hand hygiene act before entering the room. But entering the room is just one aspect. There are actually, WHO has these 5 moments of hand hygiene where to before touching the patients and all that. So we are getting into the more details of inpatient room hand hygiene project. Here's just an example showing you that we can identify these hot spots of necessary hand hygiene movements. So that was just 2 examples showing you what we can do in the inpatient rooms using ambient intelligence for healthcare. Let me just shift attention to daily living space as one final example. And the one area I personally care a lot, and I think this whole world should be caring about, is our aging population, as well as just the trend of our world become the longevity increasing. And I don't need to get into all the macroeconomic as well as the human price tag of how expensive care for aging is and how important it is. Of course, wearables technology have become a frontier in helping seniors living at home more healthily, ensuring well-being, ensuring nutritional intakes, and sending alarms. But wearable technologies sometimes are limited, and there is space for ambient sensing technology, like the one I just introduced. We have been collaborating with Unlock, a PACE program in San Francisco, and we use two types of sensors, depth sensors and thermal sensors. And what we are helping to pilot is to understand the daily activities that the seniors are performing. And through these kind of daily activities, we get to understand the well-being, or if there's early indication of clinically relevant events that we should be watching. And of course, this technology can have a lot more nuanced insights that we can deliver, whether it's early detection of infection, especially through thermal sensors and changes of respiratory rate or urinary frequencies. Mobility, we talked about it in the inpatient, but here, whether it's a fall or prediction of fall or other kind of mobility related conditions, sleep patterns really matter, as well as dietary patterns and all this are all potential areas of ambient intelligence technology. So before I wrap up, so we talked about hospital space, we talk about daily living space for ambient intelligence. Before I wrap up, it's really important to talk about the ethical and societal implications and also the practice of our research. This is something that AIMI has been a leading center. HAI has been also part of this bigger effort in AI research at Stanford, where ethics should be designed at the beginning of a project, not as an aftermath. And in the case of ambient intelligence for healthcare, there are many aspects of ethical and concerns and societal concerns we should be thinking about. One of them, of course, is privacy and security. You know, we need to think about data privacy, especially now we're in the realm of visual data. How do we protect people's identity? How do we protect people's full body information? How do we consider modern privacy computing techniques for machine learning, such as differential privacy, as well as federated learning or homomorphic encryption? These are the studies that's happening within my lab and also in many places here at Stanford. There's actually physical privacy as well in the application of this technology, going from the sensor end all the way to the server end. So this is an area that I plead to all researchers and entrepreneurs to consider when you're in the realm of ambient intelligence for healthcare. Of course, this would increase legal challenges. This new area of technology will definitely increase legal challenges that we haven't faced. For example, questions like, can ambient sensors be potential witnesses? What's the role of data? These are the questions I cannot personally answer without that kind of proper expertise, but we do engage with scholars in law school to try to study these problems. A lot of you have already heightened awareness on data and algorithmic fairness issues, and this is a talk of its own. I just want to say that this is especially important in the case of healthcare where humans are involved, from the fairness issue of the research projects itself, as all the way to the inference and decision making and application of this technology. And of course, we are trying to follow the latest and best of algorithmic fairness practice, data sheets, model cards, and all these kind of work. Of course, last but not the least, scientific integrity, research ethics, and human subject consent is really important. One of the most educational and rewarding thing to me in this 10-year journey working on ambient intelligence in healthcare is how our students from computer science world have learned to these important practice in the ethics of and integrity of scientific research. It's something that took them outside of their, at the beginning, comfort zone, took them outside of their expertise, because these are students who came from undergraduate degrees in engineering, but now they're in a new world of ethics and human studies. And it's just deeply, deeply rewarding to see our technical students becoming bilingual experts in both human-centered aspect of our research as well as in technology. So in short, all these issues I presented do not have an easy answer. They are ongoing challenges, and I don't have a simple recipe. But there's one thing that I'm really repeating what I have heard from Nigam, Andrew, Kurt, Matt already, is that it is so important for all the researchers, especially computer scientists working on AI, to consider a new kind of research approach that is what we call here multi-stakeholder approach, that in order to bake ethics into the research and technology itself, we need to invite the multi-stakeholders, in this case, clinicians, patients, policy thinkers, ethicists, legal experts, as well as computer scientists, to help answer these questions, mitigate risk, and to innovate. So in summary, I try to give you a quick overview of what I see as an emerging new, exciting use case and also research area of AI for helping patients and clinicians to illuminate the dark space of healthcare. And I will part with this important insight I've learned on my journey is healthcare at the end of the day is humans for humans, and AI is a tool, and it's up to us to use this tool to enhance our humanity and to help each other. Thank you.
Thank you, Fei-Fei. This was fabulous.
Thank you.
And it reminds me of this quip on the internet that the future is already here, but it's just unevenly distributed. And I think your talk was a great example of the things to come in the next 5, 10, maybe 15 years, and the issues we're going to have to solve along the way so that we get it right. And for those watching on the live stream, Stanford is one of those unique places where we have individuals like Fei-Fei who keep us sort of squarely focused on the human side and make sure the AI is about augmenting the human connection. And then we have Andrew, who's sort of pushing us to focus on the right data, the ML ops, and the interdisciplinary team nature. And it's just a fabulous mix to be in, and sort of takes us back to the 1970s when this field began on our campus, with the School of Medicine partnering with the then nascent Department of Computer Science. It's kind of hard to imagine somebody would call the department, Stanford CS department, nascent at any point. And the country's first supercomputer for AI in medicine, called SumX AIM, was on this campus, created by a collaboration between the School of Medicine and the Department of Computer Science back in the 70s. And our director of the AIMI Center, Kurt Langlotz, has lived that history. In fact, I'd imagine he probably had a login to that computer system at some point because it served the country for 18 years. And themes keep coming back. So one of the things that I only was touched on today, but I'm sure some of you have heard about, is chatbots to help with diagnoses and with mental health and so on. And one of the fun factoids of history are two chatbots, one called Eliza and the other called Patty. Eliza was a diagnosis chatbot, and Patty was a chatbot that simulated a schizophrenic patient for medical education. And as you can imagine, people put these two together, and there's a lively interaction between the two, documented for perpetuity on the internet. And things like that will continue to happen on this campus. Given the AIMI Center and HAI's collaboration, we saw some of the flavors in diagnostic decision making, illuminating the dark spaces of HAI, of medical care, in-home care, and so on. And it puts us in a very interesting situation of inventing the future, but at the same time recognizing and learning from the past 40 years of history of AI in medicine. So I'm absolutely delighted that we're able to do this, and we're glad to have you here. And at this point, we're about 4 or 5 minutes ahead of schedule. And the next session is going to be actually led by Jonathan Chen, moderated by Jonathan Chen, on the role of AI in diagnostic excellence, ranging from in imaging to cardiology to sort of watching over the diagnostic AI itself. And if Jonathan Chen is already here, I would like to sort of welcome him on stage, or on the virtual stage, so to speak. He's an assistant professor in the Department of Medicine, the same department I'm in. And I love to joke, the same department where Kurt Langlois graduated from way before my time. And he's going to sort of invite the speakers into this session, and we'll take it from there.